Child not responding with a traditional dose of vitamin D, and as you treat in nutritional rickets, is called refractory rickets. If you give orally non-response by 3 months, is called nutritional refractory, and non-responsiveness by stress therapy 2 doses at 1 week apart is also called refractory rickets. Non-response means the non-clinical resolution, non-biochemical resolution, and radiological resolution. So these are the rickets, like your type 25 hydroxylation takes place in the liver. First step, in when it doesn't, you have type 1b rickets. When it doesn't take place, hydroxylation doesn't take place in the renal tubule, proximal tubule, 125 dihydroxylation is not formed. We call it type 1a vitamin D dependent rickets. And when there is receptor there, the hydroxylation is all right. When the receptor disease is there, BDR, vitamin D dependent, vitamin D receptor is defective, it is mutated, you have vitamin D dependent, vitamin D type 2 rickets 2A. When there you have ribonucleoprotein defect, you have type 2B rickets. They are very difficult to treat, out of to which their type 2 is very difficult to treat. So because it is a genetic disease, severely mutated disease, very difficult to treat. So and then that's so 2A vitamin and 2B vitamin D dependent rickets, 2B and 2A vitamin D dependent rickets, or you call it resistant rickets. And other one is phosphaturic rickets, phosphopenic rickets, loss of phosphate in the urine by the genetic means, X-linked hyphosphatemia. By far the commonest one over here. These children that do pass excess amount of phosphate in the urine, that do have phosphopenia, and that do have phosphopenic rickets. So and gene is a FAX mutation. And autosomal dominant variety is also there, phosphopenic rickets, phosphoturic rickets. Autosomal recessive variety is also there, contributing to a small amount of the your phosphopenic rickets, phosphopenic also, and they have different gene mutations. So treatment of these diseases, your failure to convert, you give a little bit more doses of with the vitamin D and calcium, and in the your second that phosphoturic and phosphopenic, you give high dose phosphate. By no response to phosphate, you can use a monoclonal antibody, burosumab, which helps in the retention of the phosphate. And when you will do corrective osteotomy, if you have the control of disease in adequate time, satisfactorily corrective of disease is not coming back, you are certain, then go for osteotomy 1 to 2 years usually, and clinical resolution of rickets must be there. In active rickets, you do not go for any corrective osteotomy, corrective surgery. So genetic disease, they are lifelong disease, difficult to treat disease, especially type 2. They need very higher amount of the your oral calcium. Then even continuous calcium infusion may be needed, and very high dose of the oral vitamin D, active vitamin D, with guarded prognosis. But most of the time, the nutritional and your calcipenic rickets, good amount of calcipenic, even refractory, also phosphopenic, they do well, the response pattern is good.